Hi, welcome back to Rnpntutors USA. Today we're going to talk about congenital cardiac defects. So when we think of congenital cardiac defects, of course we have to remember how blood flows in the heart. So you want to remember a little bit about fetal circulation, but more so you want to think about the newborn's circulation. Generally, we know that blood from the rest of the body that is lower on oxygen comes into the heart on the right side, while that blood on the right side goes over to the lungs to get oxygen. And when I say go over to the lungs, it's two lungs. Gets oxygen, comes back on the left side. And on the left side of the heart, we of course push the blood out to the rest of the body. And this is the blood that's rich in oxygen. Now, when we think of a congenital cardiac defect, you first want to think that this baby was born with this heart having these problems. They're not acquired. They're born this way, like Lady Gaga would say. You also want to remember that congenital cardiac defects are separated into whether they're cyanotic, meaning that they produce or manifest blueness or cyanosis in the baby, or if they're acyanotic. So if they're acyanotic, the child still has deficiencies in oxygen and different problems, but they still get some oxygen-rich enough blood that they're not as blue as the other babies. So we could first start to talk about the acyanotic defects. And in these defects, like I said, they're acyanotic, so they're not classified as blue babies, as we would say. One of the first acyanotic defects that we could talk about is patent ductus arteriosus. The ductus arteriosus is a fetal vessel, and the function of the ductus arteriosus, in the fetus, is that it shunts blood basically between the pulmonary artery and the aorta. It allows blood to shunt around the lungs basically, because while we're inside our moms, we don't breathe the same way that we breathe in the extrauterine environment or when we get out. So what happens is it normally closes spontaneously shortly after the baby is born. And generally there's no, connection between it seals off when the baby takes that first breath and starts to breathe and all of that. And we no longer have that shunting around of the blood bypassing the lungs. Instead, we know that, of course, blood comes into the heart, goes to the lungs, and get oxygen once we're in the extrauterine environment. So over time, this fetal vessel seals off when we are born, or that's normally what happens. In the heart that has the patent ductus arteriosus, the ductus arteriosus, which is the fetal vessel, is still open. It didn't seal off. And so it's still continuing its function. It's mixing blood from the aorta, which is the aorta is that overarching large artery, or the largest artery, and it carries oxygen-rich blood out of the heart to the rest of the body. What happens with the PDA, or patent ductus arteriosus, is that we have mixing of the blood from the aorta, mixing with the blood in the pulmonary artery. So what happens is oxygen-rich blood from aorta is mixing with oxygen-poor or deoxygenated blood in the pulmonary artery. And so we have certain characteristics in this baby. For example, the child will have excessive pulmonary blood flow, meaning excessive blood flow going to the lungs. That's one of the problems. The child will breathe differently. Usually they're going to be breathing faster, having more difficulty breathing, especially when they try to feed. Because of course, whenever we, as babies, that whole suck and swallow mechanism, it takes energy. And so if you're already getting this mixed blood that is going to be lower in oxygen than regular blood, of course you're going to become more tachypnic and dyspneic, or short of breath, breathing more rapidly when you feed the child, or the child's going to experience that. Other signs and symptoms include frequent respiratory infections, and we can understand why. And one of the hallmarks is a machine type characteristic murmur that we will auscultate in this child's heart. Of course, when we listen to the cardiac sounds. So it can be treated. Usually they'll use drugs like indomethacin or indocin, or it can be surgically fixed, ductus ligation or tying it off type of thing. So you want to remember that we can treat it with medication as well as it's amenable to surgery. So to manage the child with patent ductus arteriosus, the management is similar to all of the acyanotic congenital defects. What happens is we try to minimize the need for a lot of energy. And so we want to provide much smaller frequent feedings because again, we're aware of that suck and swallow mechanism and that it causes the child to use up some energy and then need oxygen. We can provide oxygen. We can use a larger nipple to feed because that of course will increase the amount of flow of the milk or whatever the child is feeding, and so less of a stress to breathe, and so less work on the heart and lungs. Other ways that we can help, we can gavage feed the child, can use feeding tubes, those can assist as well. We can cluster care or allow for frequent rest periods so that we don't tire out the child or this baby, because we know again that they have this defect in the heart. Many of the acyanotic cardiac defects can be treated with digoxin, can also be treated with diuretics. Just remember your principles with digoxin. Always remember that you're monitoring hydration status, intake, output, always with diuretics. And of course with our babies, we wear our diapers to get an idea of fluid loss, that type of a thing. Things to know: when we give digoxin to infants, we always want to still consider our principles of monitoring for bradycardia prior to administration. Usually we hold if it's below 100 for infants and below 80 for toddlers. And then of course we know our parameters for adults. Be also very mindful that even though we might see adults on fluid restriction, this is more uncommon for infants because of course most of their body weight is fluid, most of their body composition is fluid. Other things to note: so we spoke about the diuretics, we spoke about the digoxin. It's amenable to surgery. Remember that if you're giving digoxin, it can cause nausea and vomiting, and if the child does vomit, be careful about redosing because you have to be very mindful of toxicity levels with digoxin.